respected senior professionals and dear friends, and one of the important diseases to be treated, hypertension. And one most important drugs to be used in all the hypertensive individuals are the ARPs. And the most important ARP in our India is the Telmisartan and its different combinations. So the title of our today's talk will be the Timeless Classics, Telmisartan and its combinations, trusted at every stage of our CV continuum. So this is the recent study, ICMR India study. Several times I also told these figures. The number of the hypertensives in India right now are nearly 32 crores. So a very high number of the Indians are having the hypertension. And if you see the guidelines on hypertension, and the two important guidelines are the one the American guidelines and another European guidelines. And hypertension definition by American standards more than or equivalent to the 130/80, and whereas the Europeans more than the 140/90. And for our Indian hypertensive statistics, we take the 140/90 as the figure of the defining as an hypertension individuals. And the normal BP range for our European and the Indians, the optimal is the less than 120/80. And the normal up to 130 of the systolic and up to 85 of the diastolic, and high normal when the systolic is between 130 to 139 and the diastolic 85 to 89. And hypertensive stages, we have the three stages, stage 1, stage 2, stage 3. The systolic between 140 to 160 and the diastolic 90 to 99 is the grade 1 or the stage 1 hypertension. And stage 2 is systolic 160 to 179. The diastolic 100 to 109, and the stage 3 systolic more than 180 and the diastolic more than 110. And the BP targets, if you see in the American standards, irrespective of the age, once the age is between 18 years, above the 18 years, and more than the 80 years also, the target of the blood pressure is less than 130/80. And whereas for the Europeans, for our Indian standards, for the younger age group up to the 65 years age group, it is 130/80. And more than the 65 years, the systolic may go up to the 140 and the diastolic is the 80. And more than the 80 years of age group, the systolic up to the 140 is the normal, and less than 80 diastolic is the normal things. But here again, to consider a fellow as the isolated systolic hypertension, we say the systolic blood pressure more than 140 and the diastolic normal is the isolated systolic hypertension. That is also equally important, because isolated systolic hypertension also increases the risk of cerebrovascular diseases and ischemic heart diseases. And if you see the pharmacotherapy, the initial therapy with the beta blockers reserved for the specific conditions, including the ischemic heart disease, the heart failure. So that is true for all the hypertension individuals. See, the beta blockers are the compelling indications to use it in the ischemic heart disease, to use it in the heart failure, in other conditions. So the compelling indication we have to use the beta blocker. So these are the differences between the two groups of the hypertensions. And what is the most important facts of the hypertension? This is the most important slide to be taken over to the home and for your clinics. So in a recent cross-sectional survey study of the Indian adults, this is our study, hypertension more than 1 in the 4 individuals. That's already I've given the figures. Nearly the 32 crores out of the 140 crores of the Indians are the hypertensive. That shows very lot of the more people are hypertensive. But what about the diagnosis? So diagnosis is only 1 in the 3. So that means a lot of the people are undiagnosed. They are living with the hypertension without knowing that they are living with the hypertension until they get the complications. And even after diagnosis of the hypertension, not all the people are on the treatment. Only less than the 1 in the 5 people are on the treatment, in spite of they know that they are the hypertensive. And then after getting the treatment, very few people will be on the control. So only 1 in the 12, they are in the BP control. So that means that more than 90% of the adults with the hypertension in India who are either undiagnosed or undertreated or treated but with uncontrolled hypertension. So they are not reaching the target. So the take-home message from this slide is, lot of the hypertensives are undiagnosed, so we have to diagnose hypertension. So it's opportunity screening. So whenever a fellow comes to a doctor of any specialty, so better to check the blood pressure and then diagnose whether the fellow is hypertensive or not. Who is an hypertensive? Systolic more than 140, diastolic more than 90 is an hypertensive. So that is the diagnosis of the hypertension. And later, after the diagnosis of the hypertension, when the fellow is the stage 1, so you need not put in a drug therapy. So even with the lifestyle measures, so it can continue, reduce it to about 130 by 80 or 120 by 80. So all the non-pharmacological measures like your dietary approach, your exercise, your yoga, your meditation, so all the salt restriction, more fiber diet, more fruits, etc. are very, very important to control the hypertension in stage 1 or stage 2 or stage 3. And then you see that people, they should be on the treatment, whether the non-pharmacological or pharmacological, in order to avoid the long-term complications. Otherwise, hypertension is the number 1 killer in the universe. Even today, the number 1 killer in the universe is the hypertension. So hypertension is responsible for the myocardial infarctions or the CVAs or CKD, and also your arrhythmias and aortic aneurysms or peripheral vascular diseases, etc. And then after putting the treatment, maybe one drug or the 2 drugs, so don't be happy with that drug therapy. You see that they are supposed to reach the targets. That is very important. So the target blood pressure is less than 130 by 90, or maybe the reach of 130 by 85 or 120 by 80 is our target. So this is a very, very important as far as the public health is concerned. See, the clinical trials show that BP control can be achieved in the total majority of the patients. See, if you see the majority of the patients in the trials received combination therapy. So nowadays, it is very, very difficult to control with a single drug. So that single drug, that is the monodrug therapy, reducing the blood pressure to your ideal levels is only 5 to 10% of the population. So that means that 90% of the hypertensive individuals, they need combination therapy. See, these are all the drugs. Trials, UKPDS, ABCD, MDRD, heart, hypertension, optimal treatment, OS, IDNT, value. So all these trials, the target blood pressure diastolic is 85 or 90 or less than the 90. So the number of the antihypertensive agents used, no trial with a single drug, monotherapy. Most of the trials, they use the 2 drugs or the 3 drugs, some trials even the 4 drugs also, like your IDNT trial. So that means that most of our hypertensive individuals, they need 2 drugs or 3 drugs or the 4 drugs to reach your target blood pressure of less than 130 by 85. Increasing the dose of the monotherapy versus the combination. So there are the 2 thoughts of reducing the blood pressure. So one study, one group, they say that just increase the monotherapy. Suppose if they are on 20 milligrams of the Telmisartan, 40 milligrams of the Telmisartan, increase the dose to 80 milligrams. And some people say that if the patient is getting the metoprolol 50 milligrams, so increase to 75 milligrams or the 100 milligrams. If he is getting the amlodipine 5 mg, increase to the 10 milligrams. That is one group. And another group say that, so don't increase the optimal dose of the second single drug, and you add the second drug. So let us see the results here. So the coronary events, by increasing the dose of the monotherapy, 29% reduction, and the cerebrovascular events reduced by the 40%. And if the people who are on the 2 drugs, combination therapy, so the reduction of the coronary events by 40% and reduction of the cerebrovascular events by 54%. So that clearly shows that combination drug therapy definitely reduces the events of the both the coronary and the cerebrovascular events when compared to the increasing the dose of the initial drug or the monotherapy. So the Indian registry and the current patient profiles and the treatment trends in the hypertension. See, 1 year analysis. So they say that combination therapy for hypertension is increasingly preferred at the time of the initial diagnosis itself. So now the days have come that even on the day of your diagnosis of the hypertension, so you are bound to prescribe the combination therapies because of these several reasons. See, the guideline similarities, accurate blood pressure measurement is always needed because office-based measurement. See, now the BP or the several values are there. One is office BP value. The second thing is home BP value. And the third one is daytime average blood pressure. And the fourth one is nocturnal blood pressure. See, for everyone, there the values differs to consider as an hypertensive. For example, nocturnal blood pressure. So the nocturnal blood pressure should be less than 120 by 75. If the nocturnal blood pressure is more than 120 by 75, you are an hypertensive. So that is called dipping and non-dipping. So the dipper is good, non-dipping is bad. So reducing the blood pressure during the nocturnal time maybe because of the smoking, maybe because of the excess alcoholism, or uncontrolled diabetes, or uncontrolled hypertension, or obesity, dyslipidemia. So these are the several reasons for the non-dippers. They are at high risk of getting the early hours thrombotic events. So more of the vascular events is because of the non-dipping of the blood pressure during the night time. That is the reason. When the fellow is getting the 3 or the 4 antihypertensive medications, better to give at least 1 or 2 antihypertensive medications at the night time in order to see that there will be the dipping of the blood pressure will be there. So don't prescribe 3 or the 4 antihypertensive drugs in the morning itself. So you can choose that at least give 1 or 2 anti-agents at the night time so that to reduce the nocturnal blood pressure also. Cardiovascular risk calculators for the treatment. This is very, very important. See the 10-year risk of the cardiovascular events. So when the fellow is having an hypertension uncontrolled, also diabetes, also dyslipidemia, also alcoholism, and also smoking, etc. So they are at high risk of getting the vascular event. So the 10-year risk will be more than 20%, 30%, 40%. So those people, they require more and more drugs, and also anti-thrombotic agents, and also statins, etc. On the other hand, when the fellow is a normal body weight, no obesity, and no smoking, no family history of ischemic heart diseases, and other the only except the hypertension, is not having any comorbidities, then the 10-year risk will be less than the 10%. In that way, you can use even in the monodrug therapy or in non-pharmacological management also. So all the hypertensive individuals, when they're sitting in front of you, see the 10-year risk of the atherosclerosis or the cardiovascular events, then only you can prescribe the different drugs. So the initial pharmacotherapy recommendations, already I told you, single pill combination therapy is a first line strategy for the many patients. Now the combination drug therapy is always there, and also the single drug is available with the telmisartan, with the metoprolol, telmisartan with the cilindipine, telmisartan with the amlodipine, telmisartan with the diuretic, and also the triple drug combination is also available with the ARB, telmisartan plus calcium channel blocker plus diuretics, etc. And choose so that to improve the compliance of the patient. So both American as well as the European recommends the single pill combination as the first line strategy. So ideal antihypertensive drug. See, these are ideal on the paper, not in the patient, because any drug, any antihypertensive drug should reduce the PVR, that is the peripheral vascular resistance. It preserves the cardiac output, a good blood flow, good perfusion to the vital organs, both at the rest and the during exercise. So that should be an ideal antihypertensive drug. And favorable quality of the life and side effect profile. It should not have any side effects and improves the quality of the life. Reduces the left ventricular hypertrophy. It's very, very important, because most of the people, if you see the ECG, very common finding in a chronic hypertension is the left ventricular hypertrophy. And left ventricular hypertrophy is an independent risk factor for the myocardial infarction and independent risk factor for the cardiac failure also, heart failure also. Reduces the hypertensive end organ damage. So it should reduce the retinopathy, it should reduce the proteinuria, it reduce the CKD, and it should reduce the cerebrovascular diseases, peripheral vascular disease. These are all the end organ damages. So every drug, antihypertensive drug, should reduce all these things. And drug compatibility, because the pharmacodynamics and pharmacokinetics of these antihypertensive drugs are very, very important. And it should be synergetic to the other drugs and can be given in the coexisting disorder, and once a day doses. And if you apply all these things, no single drug is there. So no antihypertensive fulfills all these qualities. So that is the reason most of our antihypertensive individuals, they need 2 or 3 drugs in order to have all these things. So the choice of the antihypertensive as per the compelling indications. Heart failure. So a lot of the people now the geriatric population, almost India is the capital for the geriatrics. So a lot of the people are beyond the 60 or 70 or 80 years of the age group. So they are at high risk of getting the heart failure with a reduced ejection fraction. So when you get the EF, it will be less than the 40 or less than the 50. So diuretics are good. Aldosterone antagonists, we have the 2 types of the aldosterone antagonists here. One is the steroidal, second one is the non-steroidal. Steroidal aldosterone antagonist is the spironolactone or eplerenone, whereas the non-steroidal aldosterone antagonist is the finerenone. So earlier we have taken one lecture on the finerenone also. It's a very emerging drug, very good drug, especially in the type 2 diabetic individuals. Beta blockers, you have the metoprolol, carvedilol, bisoprolol, nebuvolol. Calcium channel blockers, you have the amlodipine and cilindipine, ACE inhibitors and ARBs. So these are all useful in the heart failure population. So in the heart failure, you are supposed to use the 4 or the 5 drugs. 4 pillars of the management of the heart failure. One is the ACE or ARB or ARNI. The second one is the beta blocker therapy. The third one is the aldosterone antagonist. And the fourth one is the SGLT2 inhibitors. Heart failure, the preserved ejection fraction, you can use the diuretics when the failure is the edematous or the beta blockers. See, cardioprotective beta blockers like your metoprolol or carvedilol bisoprolol, not your etenolol or your propranolol here. ACE inhibitors, ARBs are very good in the heart failure management. Stable ischemic heart disease, you can use the diuretic like indapamide or hydrochlorothiazidone. You can use the aldosterone antagonist like the finerenone or the spironolactone. The lower dosages, beta blockers are the compelling indication. Calcium channel blockers like verapamil, etc. You can use it here. Diltiazem. ACE inhibitors you can use. ARBs you can use it. And chronic kidney disease, so ACE or ARBs are the very important drugs to be used. And post-renal transplantation, you can use the calcium channel blockers and the ACE inhibitors. Diabetes mellitus, so compelling indication is the ACE or ARBs, calcium channel blockers. Once the potassium levels are very high, once the creatinine levels are very high, so you can use the calcium channel blockers. And then the diuretics are the very important drugs to be used. Second is stroke prevention, ACE or ARBs. Atrial fibrillation, so ARBs and the peripheral arterial disease, so calcium channel blockers, ACE and ARBs, etc. And the black race, mostly the Africans, so they are more they are very responsive to the calcium channel blockers and also the diuretics. So these are the compelling indications. And if you see here, most of our conditions, whether the heart failure or the ischemic heart disease or the diabetes or the CKD, etc., ACE or ARBs are the compelling indications to be used in most of these conditions. Patients are more likely to persist with the ARBs with other antihypertensive medications. If you see here, adherence ratio with the ARBs good when compared to the ACE inhibitors, because ACE inhibitors they cause cough. The incidence of the cough is more with the ACE inhibitors, and also the angioneuritic edema is also more with the ACE inhibitors. So, if the patient is not tolerating the ACE inhibitors, you can change out to the ARBs. And if the fellow is getting the cough and the edemas, angioneuritic edemas is one particular ARB like your Telmisartan, you can change over to the Olmesartan or the Valsartans. So the basic single pill combinations with the ARBs plus beta blockers like the metoprolol. See that here, a combination how it works. And you all know that angiotensinogen will be converted to the angiotensin 1 with the help of the renin. So renin is coming from the kidneys and angiotensin is from the liver. And now the renin converts the angiotensinogen to the angiotensin 1. The angiotensin 1 will be converted to the angiotensin 2 with the ACE. ACE will coming from the lungs. And angiotensin 2 you will have the AT1 receptors and the AT2 receptors. So AT1 receptors are more important because they are more vasoconstrictors. They increases the sympathetic activity. So they cause more sodium and the fluid retention. So by blocking these ARBs, by using these ARBs, you are blocking this AT1 receptor activity. So ARBs are used to reduce your vasoconstriction. So more and more vasodilatation, to reduce your sympathetic activation. So the heart rate will not be increased more, and they reduces the sodium and water retention. So the blood pressure will come down. So the ARBs will act by vasodilatation, by reducing the sympathetic activity, and by reducing the sodium and fluid retentions. So how the beta blockers act? So you know that beta blockers, they reduces the heart rate. So they reduces the force and rate of the contraction. So they reduces the cardiac output. You know that cardiac output and peripheral vascular resistance, these are the two integral parts of the blood pressure management. So by using the telmisartan, you are putting the vasodilator, and by using the beta blockers like the metoprolol, you are reducing the cardiac output and the heart rate. So that is how they are synergetic, and they are very helpful in reducing the blood pressure in these two ways. So both are cardioprotective drugs. The beneficial of the hypertension based on the coronary artery disease or the heart failure, used for the secondary prevention of the cardiovascular events when the major goal of therapy is improvement of the outcomes. This combination is likely to exert important benefits in patients with hypertension. See the basic concept of the CV continuum. So this is the first coined by the John the Braunwald. So Braunwald has written a beautiful textbook on heart diseases, Braunwald's textbook of cardiac diseases in 1991. He said that cardiovascular conditions such as angina or myocardial infarction, congestive heart failure are the late complications in a progressive pathogenic process. See, it gives a lot of time for us. Hypertension. So today's hypertension, you will not get the myocardial infarction or the heart failures next day or the next month or the next year. So it will take a long time, maybe 5 years, 10 years, 20 years to develop all these things. That is the time we have to respect all the hypertensive individuals to reduce the blood pressure as much as normal as possible. Otherwise, if you keep the blood pressure for long days or the months or the years, so definitely we can invite all these things. So how? There are the risk factors. You all know the risk factors like hypertension, disorders, lipid disorders, diabetes, smoking. So they promote the atherosclerosis. So the promotion of atherosclerosis of the coronary arteries. So they become the ischemic. And then there will be the plaque formation, the plaque rupture, and the thrombus formation. So they cause the myocardial infarction. Some unlucky people, they will die immediately after the myocardial infarction. So sudden cardiac death is there. Some lucky people, they reach to the cardiologist, and then with the PGC or the CAPG or with your intensive medical management, they live for the longer period. And because of this necrosis, so there will be the reduction of the contractility, and finally there will be the left ventricular dilatation, and there will be the remodeling, and the heart failure will come after 10 years or 15 years, 20 years of the ischemic heart disease. So the most important cause of the heart failure in Indian population is the ischemic heart disease. There are the 4 or 5 causes of the heart failure in India. One is the ischemic heart disease, 2 is the diabetes, 3 is the hypertension, and 4th is the anemia, etc. And rheumatic heart disease, now they are at the latter stage or at the lower grade. So this is your Braunwald and Jaws CV continuum. So that means that with the risk factors, these people will get either the myocardial infarction or the heart failure at a later time. So by using the beta blockers, how the beta blockers help? If you see the atherosclerosis and left ventricular hypertrophy, so by using the beta blockers and the ARBs, so the LVH will be reduced, and coronary artery disease risk reduction will be less, and myocardial ischemia will be reduced, and there will be the neurohormonal activation, so myocardial infarction risk will be less, and arrhythmias and the sudden deaths will be reduced with the beta blockers. In fact, the beta blockers reduces the mortality and gives the good quality of the life in the ischemic heart disease population. And beta blockers will reduce the ventricular enlargement, so finally the heart failure incidence also will be reduced. Even if they get the heart failure, the beta blockers are a compelling indication to use the beta blockers in the heart failure, and finally the death. So in all these stages of your CV continuum, so there is always a big role to use the beta blockers. So the beta blockers, not only here, so you have the alpha antagonism, beta 1 antagonism, beta 2 antagonism, and the beta 3 agonism. So in all these areas, whether the vasodilatation or chronotropy, inotropy, lysotropy, RAS activation, vasodilatation, so these beta blockers have a role. So these are the pathophysiological mechanisms of the beta blockers. So you have the class 1 recommendation with the level A. So among all the BP lowering drugs, ACE inhibitors, ARBs, calcium channel blockers, diuretics are very important drugs, first line agents. Yes, we are using them. And what about the beta blockers? So beta blockers are combined with any other major BP lowering drug classes. They are the compelling indications to use in angina, post myocardial infarction, heart failure with reduced ejection fraction, or for the heart rate control in tachyarrhythmias. Again, the beta blockers are the compelling indications to be used in the class 1 and the level A. So this is how we have to use the ARBs and the metoprolol or your beta blockers here. So the low dose always start, as I told you, that the initial combination therapy of the antihypertensive medication is very much needed, because a combination drug therapy will reduce the complications of your hypertension, and it gives a good quality of the life instead of increasing the initial monodrug therapies. So use the low dose of your combination therapy as a step 1, and step 2 you can add the triple drug therapy, and the step 3 you can increase the maximum tolerated dosages, and then you can add the spironolactone or the beta blockers, etc. But a stage will come where the beta blockers are a compelling indication to be used, as I told you, that angina, myocardial infarction, congestive heart failure, where you have to use the cardioprotective beta blockers as a compelling indication to reduce the heart rate and to reduce the LVH and to improve the standards of the life and to reduce the mortality. Various guideline recommendations for the beta blockers in hypertension. So initiation of pharmacological therapy, already I told you. Choice of the initial antihypertensive therapy depends on the drug. So when to consider beta blocker, already told you the compelling indications and contraindications. See, earlier when we were undergraduates or postgraduates, the contraindications to use the beta blockers are the asthma or bradycardia and then AV blocks and then the sinoatrial blocks, etc. Now they are not the compelling contraindications. They were the relative contraindications. So even in such situations, so you can use the beta blockers which are cardioselective, like the beta 1 protective. So like your bisoprolol or carvedilol, you can use in those conditions. So even then, so compelling contraindications right now are the bradycardia when the heart rate is less than the 60, or SA block or AV block, and other contraindications are the relative contraindications. So the research for the last 3 decades has continued to reveal a new and sometimes the benefits of the beta blockers, like the heart failure. So you have to use it. I already told you one of the 4 pillars in the management of the heart failure is the cardioselective beta blockers, and other 3 pillars are the ACE or ARB or ARNI. One, number 2 is the MRA antagonists like your spironolactone or finerenone, and then the SGLT2 inhibitors. These 3 are the other pillars, and the 4th pillar is the beta blocker. Acute myocardial infarction, yes, we have to use the beta blockers at a lower doses initially, and once the fellow is a stable coronary artery disease, definitely there is a compelling indication to use the beta blocker. That is a class 1 and level A. And tachyarrhythmias, so we have to use them in all the hypertensions whenever there is a needed. So definitely we have to use the beta blockers. So now the concentration of the heart rate. So earlier heart rate tachycardia means heart rate more than the 100, but for us the tachycardia means more than the 90, and some people say even at more than the 80 also, the resting heart rate. So high resting heart rate more than the 80 in hypertension indicates the increased sympathetic activity. As the heart rate rises, there is a higher risk of the atrial fibrillation and mortality in the general population of the hypertensive patients. So we have to respect the heart rate also in all our hypertension individuals. So once the heart rate is more than the 90 or the more than the 100, so there is always an indication to use the beta blockers, because more the heart rate, more the chances of having the tachyarrhythmias and the early death. So the beta blocker should be considered as the first drug treatment of choice for hypertension patients with a resting heart rate more than the 80 beats per minute. See how they benefit. So blood pressure and the heart rate. So heart rate catecholamines and then the noradrenaline. So these two will be increased in the presence of that increased heart rate. So definitely by using the beta blockers, so we can control the catecholamine release and the noradrenaline, and definitely it protects the heart. So elevating the resting heart rate are seen in the young hypertensive patients with so-called hyperkinetic circulation. Detrimental effects of the CV system: increasing the cardiac work, myocardial oxygen demand, increasing the arterial wall stress, decreasing the arterial distensibility, and they facilitate in the coronary plaque disruption. So both the guidelines, they recommend the beta blockers as the first choice of the drug treatment of the hypertensive patients with the resting heart rate values more than the 80 beats. See here the beta blockers. So oral treatment of the beta blockers is indicated in patients with heart failure or the left ventricular ejection fraction less than the 40%, unless contraindicated the class 1 and the level A. So these already I told you. So this is the guidelines. So we often follow this. Step 1, ACE inhibitors or ARBs or the beta blockers or the diuretics. And then the fellow is having the angina, you can have the dihydropyridine calcium channel blockers. Increase the full dose if well tolerated. Without the angina, you can use the diuretic also. So metoprolol in patients with the high risk hypertension individuals. So this is a MAFI study. So they said that the difference of the 48% the total mortality, which was statistically significant. So what is the study? Metoprolol significantly reduced the rate of the plaque progression in the carotid bulb at both 18 and 36 months. So total mortality and the cardiovascular events were significantly lower with the metoprolol. So the beta blocker usage, so you are reducing the plaque progression. So it reduces the atherosclerotic burden and the load also. So these studies, so they compared the metoprolol with the bisoprolol. Role of the telmisartan and the metoprolol and hypertension with the elevated heart rate. So the adrenaline and increased heart rate increase blood pressure. So the beta blockers, they block the beta receptors and prevent the adrenaline from binding to the receptors. As a result, they reduce the stress on the heart and the blood vessels. Management of the hypertensive patients with ischemic heart disease and the role of the fixed dose combination of the Telmi plus metoprolol. So the prevalence of the hypertension with IHD in Indian clinical practice, patients with hypertension and IHD between the age group of 25 to 50 and 50 to 75. Age group of the patient with the hypertension with IHD between the 40 to 60. See these physicians, about 49% of the physicians reported 25 to 50% of the patients with hypertension with IHD. And 4% of the physicians reported more than the 75% of the patients with hypertension and IHD. Maybe the cardiology practice physicians. Most of the male and the female patients who present with hypertension and IHD lie in the age group of 40 to 60 years. So that is the most important point. So most important is our early onset of the hypertension of Indian patients. Early onset of the complications of hypertension in Indian patients. So our people are having the hypertension at the age of 18 years, 19 years, 20 years, and they are getting the IHD or CKD or other things at the age of 30 plus or 40 plus. So this is the proportion of the majority of the clinicians preferred fixed drug combination of the AR with the beta blocker. So we often use the fixed drug combinations because of the good compliance. Metoprolol is preferred by 91% of the clinicians the combination that with the Telmisartan, but I don't think so in our place. So we use the Telmisartan with the diuretic, we use the Telmisartan with a calcium channel blocker, and we also use the Telmisartan with the beta blocker. But I think that maybe 40 to 45% is the right in our place, because we use more of the Telmisartan plus calcium channel blocker plus diuretic as the initial agent of the choice. When the failure is IHD, etc., whatever I told you, the compelling indication. So definitely we add beta blocker in them. So in summarizing this combination of the Telmisartan and the metoprolol, hypertension is a critical risk factor for the CV disease. That is very, very important. Number one killer in the universe is the hypertension. And think hypertension means more than 140/90, and the fellow is more than 140/90. Don't please advise the non-pharmacological management also along with your pharmacological management, because non-pharmacological management also plays a major role in controlling the hypertension. Multiple antihypertensive agents are needed to achieve the target BP. More than 80 to 85% of the people, they need multiple drugs. So single drug, fixed drug combinations with the greater efficacy, reduced pill burden, reduced cost, greater BP and heart rate reduction with your beta blocker therapy, and good adherence to the treatment. So these people will have combinations likely to exert important benefits in patients with hypertension. In the next few minutes, we'll move on to the ARBs with calcium channel blockers. So calcium channel blocker, we have the amlodipine and the cilindipine, and amlodipine is available all over the world. Lot of the literature is on the amlodipine, whereas the cilindipine is available only in India and some parts of the Asia, not in Europe and not in Australia, not in US. Unique dihydropyridine derivative L-type calcium channel blockers. See, you have the L-type and the N-type channels, calcium channels in these individuals. And the amlodipine blocks only one type of the channels, whereas cilindipine blocks both the channels. So cilindipine may reduce the risk of the cardiovascular disease along with the sympathetic nerve activation. Cardioprotective actions are probably associated with the blockade of the N-type channels and of the antioxidant effects. Favorable effects on the heart rate, they does not cause the reflex tachycardia, unlike your amlodipine. Improvement of the insulin resistance, antioxidant action, inhibition of the NADPH oxidase, derived superoxide production in the kidney. So they reduces the proteinuria and nephroprotective. So the renal protection with the cilindipine significantly decreases the urinary albumin excretion without affecting the serum creatinine concentration in the hypertensive patients. Renal protective in greater than the L-type calcium channel blockers like amlodipine. So from the clinical trials, cilindipine versus the amlodipine, that is a Carter study, is superior to the amlodipine in preventing the progression of the proteinuria in patients with the hypertension and the CKD when coupled with the RAS inhibitor. The cilindipine study, proteinuria can be decreased by switching from a L-type CCB to the cilindipine, thereby improving the renal function. So this is another study, Sakura trial. Cilindipine offered a similar protection as amlodipine in RAS inhibitor treated hypertensive patients with type 2 diabetes and microalbuminuria. Cilindipine has an antihypertensive effects equivalent to those of the L type, like amlodipine. In patients with CKD, proteinuria can be decreased by switching from an L type CCB to cilindipine, thereby improving their renal function. They are both useful antihypertensive drugs. Both are useful for preventing the vascular complex. See, in fact, a best antihypertensive action is the calcium channel blockers. So if you take a reduction of the systolic or the diastolic, is more with the calcium channel blockers when compared to the ARBs. But we always use the ARBs as the initial drugs because of its vascular protection, renal protection, the cardio protection. But most of our people, they require 2 or the 3 drugs. So that is the reason there is always a scope to use the calcium channel blockers as the combination drug therapy along with the ARBs. See the amlodipine, it blocks the L-type channels, so the vascular contraction, so that will be the vasodilator. Whereas the cilindipine, they block the both L and N-type. So N-type release, that means the vessels in the alpha-1 receptor, beta-1 receptors in the heart, and in the kidneys in the beta-1 receptor. So they reduces the tachycardia. They reduces the activation of the RAS activity. So that is how it has both the L-type and the N-type. But this is the mostly of theoretical studies. But when you see the practicality, I don't find that cilindipine is very, very, very superior to the amlodipine. So as far as my practice is concerned, when the fellow is happy with the amlodipine, without any reflex tachycardia, without any pedal edema, and when you are happy with the amlodipine as far as the antihypertensive action is concerned, so let us continue the amlodipine only. But those people who are developed the side effects of the amlodipine, like the pedal edema, etc., so then there will be a choice to use the cilindipine in the place of the amlodipine. Otherwise, you can choose the cilindipine as the initial agent of the choice. So amlodipine versus cilindipine heart rate, amlodipine can cause the reflex tachycardia in some individuals. That is the reason some people they complain of the headache after using the amlodipine. Increased heart rate is a possible risk factor for the cardiovascular events. Always increased heart rate, so definitely we have to think of it, because increased heart rate will increase the cardiovascular events. Cilindipine has a favorable effect on the heart rate, does not cause the reflex tachycardia, and has a protective role on the cardiovascular events. So RSDDA, the Research Society for the Study of Diabetes in India, cilindipine is recommended ARBs for better cardiovascular and renal protection in diabetic hypertensive patients. ARB plus cilindipine helps in reducing the morning home systolic blood pressure in elderly patients. Already told you the tippers and non-tipping. So definitely the nocturnal blood pressure should be less than 120/75 to avoid the early morning events. It improves the insulin sensitivity through its vasodilator effects. Cilindipine has various protective and cardioprotective benefits. So incidence of the pedal edema are lower than the cilindipine. Cilindipine facilitates the BP reduction and helps the heart rate and the serum triglyceride levels in Indian patients. So the management of hypertension patients, the diabetes and hypertension in Indian population, we use all these 4 drugs: ARBs, ACE, CCBs, and the diuretics. So in summarizing, different and the complementary mechanism of the actions, effective and sustained decrease in the blood pressure in patients with the moderate to the severe hypertension, cardiovascular renal protection, favorable effects on the insulin resistance, and convenient once daily administration. But still, I think 20 to 25% of our diabetic and hypertensive individuals, they are not happy with the Telmisartan or the cilindipine or the calcium channel blocker or the diuretics. So you have to use maybe the 4th drug or the 5th drug also to reduce the blood pressure of your target of 130/80. So in that you can add your alpha blockers, or you can add a central acting drugs like arcamine, or you can use the hydralazine in some individuals. So in 80 to 90% of our population, you will be controlled very effectively with the ARBs and the calcium blockers and the diuretics. And definitely 10 to 25% of the people, they may need alpha blocker, they may need a central acting drug, or they may need a vasodilator, etc. So thank you very much for your patient hearing.